Yes, Ebolina, we can go ahead.
Okay, ma'am. Okay. Thank you. A very good evening and a warm welcome to all the doctors to this Clinic webinar, the experts in conversation with Dr. Ritu Sampari. With ma'am, today we have Dr. Shadi Salim with us as a keynote speaker. Today we are very much opportunate to have these two speakers with us on our platform, and the topic which is going to cover is ultrasound in infertility. So without taking much time, I would like to welcome our today's two speaker, Dr. Shadi Salim first. Sir is President of MAMM, founder of Arab Aesthetic Gynecology Diploma, board member of WSCG, which is World Society of Cosmetic Gynecology, chief board member of Women Health Center, New Cleopatra Hospital. Welcome to our session, sir. Next, we have Dr. Ritu Sampani, ma'am, very well-known figure. Ma'am is MD, FICOG, FIAOG, AMRCOG, director at Pune Test Tube Baby Center and Shyam Meloman Clinic, obstetrician and gynecologist, cosmetologist, and IVF specialist. So now I would like to hand over the session to ma'am. Over to you.
Thank you. Leaders become great not because of their power, but because of their ability to empower others. So friends, today we are having a very great leader with us, Dr. Shadi Salim. A very, very warm welcome, doctor. So I am honored and privileged to have you with us. In spite of having your very busy schedule, you have accepted our invitation, and Dr. Shadi is going to discuss with us today a very, very important topic, the ultrasound and infertility. So Dr. Shadi is an ocean of knowledge. I came in his connection from last 2 years. How much I have learned from him, I can't tell. He's always ready to help. So without wasting time, so I am handing the dais to Dr. Shadi Salim. We are going to discuss today's topic, and very warm welcome to all of my dear friends who have joined all across the geography. And I request to all of you, whatever the queries, please write in the chat box. Post the session, we are going to discuss all the queries. So, and thank you, Clivenet team, for being always ready, having a constant support for my all academic programs. So, Dr. Shadi, over to you. A very, very warm welcome. Namaste.
Many, many thanks, my dear Dr. Ritu, for this nice introduction. And I am very happy to be with you to spread our knowledge all over the world, especially for our Indian colleagues. So can I start share my screen?
Yes, yes. We all are waiting.
Okay, many thanks for you. We will talk today about the role of ultrasound in subfertility. Subfertility, we will talk about workup for subfertility. We talk also about the role of ultrasound in assisted reproductive technology. And also we will talk about early pregnancy scanning, number of gestational sacs, viability, and ectopic pregnancy. First of all, we talk about the workup of subfertility. We will talk about the role of ultrasound in uterus, ovary, fallopian tubes, others. Ultrasound is very important. It's very important in diagnosis of congenital uterine abnormalities and also uterine pathology, like fibroid, adenomyosis, and polyps. This is classification. Also, you know, the diagnosis of congenital uterine anomalies before depend on the combined hysteroscopy and the laparoscopy. But in the era of the vaginal 3D, now is the gold standard of diagnosis of congenital uterine abnormalities is vaginal 3D. As we know, the uterus is composed of two Mullerian tubes. These Mullerian tubes fuse together to make a uterus. Maybe these Mullerian tubes not fused at all in uterine didelphys or incomplete fusion, so make the varieties of congenital uterine anomalies as bicornate uterus, septate uterus, subseptate uterus, arcuate uterus. So the most important thing in diagnosis of congenital uterine abnormalities is vaginal ultrasound. Also, these congenital uterine abnormalities affect the fertility of the lady through congenital uterine abnormalities, increase the incidence of preterm labor, increase the incidence also of miscarriage. Vaginal 3D make a revolution in the diagnosis of congenital uterine anomalies. As in the past, we used 2D to bring the mid-sagittal view of the uterus, the picture B, and also we can bring a transverse view of the uterus, which is picture A. But the revolution occurs when we can bring the coronal view of the uterus, which is picture C. As before, we cannot differentiate between bicornate uterus, subseptate uterus, or septate uterus by 2D. But now, by vaginal 3D, we can differentiate properly between the different Mullerian anomalies through the coronal view of the uterus. You see this picture A, transverse picture of transverse view of the uterus. Picture B is mid-sagittal view of the uterus, but picture C show subseptate uterus. As we show, we see the defect, or there is a deprivation present in the bottom, in the apex of the uterus. You see in the picture A, there is two cavities in transverse view. Picture B, completely normal. But when we do vaginal 3D, we see a large septum reach to the internal os. So the name of this septum is septate uterus. Before, we cannot really do diagnosis for septate uterus except when we do combined laparoscopy and hysteroscopy. But now it is very easy, and we can do it in outpatient clinics if we have the vaginal 3D machine, and also must have a professional doctor can interpret these pictures. As we know, congenital uterine anomalies associated with a range of adverse reproductive outcomes. Septate uterus had a higher proportion of first trimester loss compared with women with no septate uterus. Women with arcuate uterus had greater proportion of second trimester loss and preterm labor. This is the first issue. Use ultrasound in uterus is diagnosis of congenital uterine abnormalities. The second issue is diagnosis of pathology of the uterus. The most common pathology affect the uterus of the lady in reproductive age is uterine fibroids. Uterine fibroids is the commonest tumor in women. About 20 to 25% of women affected by fibroid in the reproductive age. Uterine fibroids may be submucous, must be removed, intramural, and subserous. There is no interference with subserous fibroid except if making a compression on the surrounding. Submucous fibroid must be removed by hysteroscopy, and the debate is about management of intramural fibroid. Another pathology we can diagnose it by ultrasound in uterus is uterine polyp. If we check on the picture on the left side, we see the endometrial thickening present in the uterus. But when we inject saline in sonohysterography, the potential cavity of the endometrium opened, and we can see the polyp very clearly. So we can enter by hysteroscopy to remove it. Also, we can diagnose polyp by vaginal 3D. You see the letter P means polyp. We see the polyp clearly when we do vaginal 3D. Also, we can do vaginal 3D and vaginal 4D with sonohysterography. We can inject saline and make 4D to see the saline moving inside the uterus and also going to both tubes. This is the first issue used in workup in diagnosis of subfertility. Now we talk about both congenital anomalies of the uterus and also talk about the major pathology occur in the uterus, which is fibroid, polyp, submucous fibroid, also adhesions. Now we talk about the ovaries. The main problems can be diagnosed by ultrasound in case of infertility is polycystic ovary syndrome and ovarian cyst. As we know, there is many types of ovarian cyst. There is functional ovarian cyst, there is endometrioma, there is dermoid cyst, there is hemorrhagic cyst, maybe locally malignant tumor, etc. All of us know different types of cysts which can affect the fertility of the lady, especially dermoid cyst and endometrioma, as these may need excision of these cysts. And also, I want to remind all my colleagues, if the patient complaining of infertility, please don't remove the endometrioma, as if you remove the endometrioma, you must take from the ovarian reserve of the lady, and this can lead to decreased antral follicle count and decreased anti-Mullerian hormone, and you can do a iatrogenic poor responder. So please, if the lady have no children, please don't touch the ovary. Please do firstly IVF. After that, after the lady can complete her family, you can remove if you want to do laparoscopic cystectomy. This is the first issue. We can use ultrasound in it in cases of infertility, in the case of check the ovary. Another thing we use ultrasound to diagnose it is polycystic ovary syndrome. We overdiagnose the polycystic ovary syndrome. Polycystic ovary syndrome cannot be diagnosed only by ultrasound, as all of us know Rotterdam criteria: history and examination, hyperestrogenism, and ultrasound features of PCO. But don't use ultrasound alone in diagnosis of polycystic ovary syndrome. All of us know the role of tin. The ovarian volume must be large, more than 10 centimeter, and also there is more than 10 follicles scattered all over the ovary, and also the mean follicular diameter of these follicles less than 10. This is rule of 10. Many follicles, more than 10 follicles, now more than 18 follicles. Also, the volume of the ovary is more than 10. Also, there is many number of follicles, and mean follicular diameter is small, less than 10 millimeter, from 2 to 8 millimeter. This named polycystic ovary ultrasound features. This is not polycystic ovary syndrome. We can diagnose polycystic ovary syndrome if we find another thing with ultrasound features, as hyperestrogenism, even clinical or biochemical, and also if we find history of the lady there is no ovulation or very little ovulatory cycles in this lady. After we check the uterus and after we check the ovary, now we look for fallopian tube. Through the main pathology can affect the tube is hydrosalpinx, and also we can use ultrasound to make a tubal patency test. Firstly, we use the hysterosalpingography to make a tubal patency test, but now we can use a sonohysterography to check the patency of fallopian tube. We put the vaginal ultrasound and check the Douglas pouch. If there is any fluid present in the Douglas pouch, we can inject saline. If some fluid pass and we see it in the Douglas pouch, this means at least one tube is patent. And if you are a rich man, you can bring a special gel to make a sonohysterography, which is named Hycosi. This special gel is, we can see it passing through the fallopian tubes to detect if this tube is patent or not patent. And this is better than hysterosalpingography, as there is no exposure to X-ray, there is no exposure for dye. Many people are hypersensitive to dye. So we use ultrasound in diagnosis of tubal patency. The main pathology can affect the tube is hydrosalpinx. What is the problem of hydrosalpinx? The problem is this fluid is toxic for embryo. So the incidence of failure of implantation or early miscarriage increased with the presence of hydrosalpinx. So if you diagnose by ultrasound there is hydrosalpinx present in this lady, you must do laparoscopic tubal disconnection, and also you must evacuate this fluid, as this fluid can make a chronic pelvic pain for lady. You can do just salpingostomy and evacuate and wash all this fluid to prevent chronic pelvic pain, which can affect this lady due to this large, huge mass present in the pelvis. After we check the uterus and ovaries and also tube and know the role of ultrasound in workup of a case of infertility, now we talk about the role of ultrasound in assisted reproductive technology. We talk firstly about monitoring of ovarian response, timing of procedure, oocyte retrieval, embryo transfer under ultrasound guidance, prediction of ovarian response, and pregnancy. First of all, we do in the second or third day of the cycle, we do vaginal ultrasound. For what? To check the ovarian volume and also to count the antral follicles present in both ovaries. The antral follicle count is most accurate parameter for fertility of the lady after age of the lady. So we must count the antral follicles in both ovaries, normally from 10 to 15 antral follicles. But if the number in both ovaries less than 4 to 6, this means this lady will respond poorly to induction of ovulation. If the follicles more than 18 to 20, this means this lady have a higher number of oocyte. This means this lady at high risk of ovarian hyperstimulation syndrome. So ultrasound detect the response of lady to induction of ovulation. If the antral follicle count is little, less than 4 to 6, this means that this lady will be poor responder. If the antral follicle count from 10 to 15, this means this is normal responder. If the antral follicle count more than 18 to 20, this means this lady will respond high responder and maybe enter in ovarian hyperstimulation syndrome. This is the first important issue in using of ultrasound in ART. The second issue is during induction of ovulation, we must do folliculometry. Why? Folliculometry means measuring of the mean follicular diameter. As you see, I can measure from here to here, from inside to inside, and from here to here, as we can take a mean of both diameter to check the mean follicular diameter. Ultrasound is very important to adjust the dose of gonadotropin, as if the follicles is hugely enlarged rapidly, we can decrease dose. If the follicles not respond properly, we can increase the dose of gonadotropin. All these can be done by ultrasound. Also, during down regulation and starting long protocol of the lady, after 2 weeks of gonadotropin releasing hormone analog injections, I ask the lady to come and I must do vaginal ultrasound to check both ovaries and uterus. The endometrial thickness must be thin, less than 6 millimeters, And also, ovaries must be, there is no ovarian cyst present in both ovaries. And also, we can check the mean follicular diameters of the follicles, as I want all follicles less than 8 millimeter. Ultrasound also important. We can do Doppler ultrasound for ovarian artery, as I want ovarian artery resistance index 0.9. After that, when the follicles, growing follicle, after reaching of the most of the follicle to 18 to 24, I take a decision to give a triggering to detect the time of operation. So ultrasound is very important to detect the time of IVF operation, and also can detect the IOI operation, time of IOI operation. After that, I will go to IVF center and aspirate the follicular fluid, doing ovum pickup. How I can do ovum pickup? I can do ovum pickup by also vaginal ultrasound, as I'm putting the needle guide on the vaginal probe and introduce the aspiration needle inside this needle guide and start to aspirate the follicular fluid from each ovary. After finishing the oocyte retrieval, I'm asking the lady to come after 3 to 5 days to make an embryo transfer. Embryo transfer, the urinary bladder of the lady must be full, and putting abdominal probe on the abdomen of the lady to see the endometrial line is elongated like this to bring a mid-sagittal view of the uterus, and introduce the catheter of embryo transfer inside the cervical canal. The outer sheath must pass internal os, and then introduce the inner sheath of embryo transfer catheter to the mid cavity of the uterus, and then inject the embryo inside it. So ultrasound is very, very important in artificial in IVF. Also, we can follow the response of the ovaries to gonadotrophin, as if there is poor ovarian response, we can counsel the patient about cycle cancellation or poor pregnancy rates. Also, we can follow by ultrasound if there is excessive ovarian response, and must counsel the patient about risk of ovarian hyperstimulation syndrome. Normal ovarian volume is from 5 to 7 centimeter. If the ovarian volume less than 2 to 3 centimeter, this means this is small ovary, and if the volume of the ovary more than 10 centimeter, this means large ovary. Also, I tell you before, antral follicle count is the most important parameter in fertility of the lady after age of the lady. Now we must tell you about this is very important issue. This is endometrial receptivity. Endometrium become receptive if the endometrial thickness and volume, endometrial pattern, Doppler study of uterine vessels, endometrial and subendometrial vessels, 2D blood flow indices, 2D power Doppler indices, objective assessment of blood flow towards endometrium and subendometrial regions. You see in this picture, this is a trilaminar endometrium. During time of ovum pickup, must check the endometrium, and the endometrium must be trilaminar, and the endometrial thickness must be from 8 to 14. If endometrium is less than 7 millimeter, implantation will be very difficult to occur. Also, if the endometrium is very thick, more than 14 millimeter, this also can lead to failure of implantation. Also, endometrium must be trilaminar. You see, this is homogeneous endometrium. Homogeneous endometrium implantation also very difficult to occur with it. But endometrium must be trilaminar, and thickness of it must be from 8 to 14 millimeter. Also, we can check the uterine artery Doppler to see pulsatility index of uterine artery. This is not a routine, not routinely done by IVF specialists, as not all IVF specialists know how can do uterine artery Doppler. But if you can do it, please do it. Pregnancy decreased when uterine pulsatility index was equal or more than 3.3 to 3.5, and RI of uterine artery was more than or equal to 0.95. The pregnancy decreased. So if you find the PI and RI of uterine artery like this, please don't do embryo transfer in this cycle. Ultrasound signs of impaired implantation at the time of HCG administration. If we find these signs, implantation will not occur. So please check this sign. Implantation will not occur if endometrial thickness less than 7 millimeter. The endometrial implantation will not occur also if endometrial volume less than 2 centimeter. Endometrial thickness if more than 14 millimeter, also implantation not occur. Absence of multi-layered endometrium, trilaminar endometrium, is important for implantation. If there is absence of trilaminar endometrium, this means no implantation will occur. If uterine artery Doppler more than 3 PI, this means no implantation occur. Also, if there is absence of subendometrial or reduction in the endometrial vascularized area, this also means implantation will not occur. And many thanks for you, and I am ready for any question.
Thank you, Dr. Shadi, for such an excellent lecture. Thank you so much.
Many thanks for you, my dear Dr. Ritu. Are there any questions for any colleague, from any colleague?
We will receive some questions.
Okay, you can ask me.
We will wait now. We will wait if we will get some questions. So, Dr. Shadi, as this my program name is the Icons in Conversation with Dr. Ritu. So, we will take some questions also. So, before that, I want to have some conversation with you. So, okay. So we are going to have this rapid fire round in which you have to answer in one word. Answer in one word for the question without thinking much. Whatever. Okay. So I'm starting my this rapid fire round. So friends, we will take your questions also because it's a great opportunity to have a conversation with Dr. Shadi.
Thanks a lot.
So Dr. Shadi, as I also know that you love to travel. So, so now, which is your favorite place where you have visited, where you have traveled?
I wanted to travel to India.
No, that you want to travel to India. Of course, you are most welcome. And till now, which place you have visited? Which is your favorite? Till now, which place you have visited?
Italy is an open museum, especially Rome, a very, very nice place. And this is very, very nice history and ancient history, very nice for me,
Okay.
like Egypt and India.
Okay, okay, great. So, Dr. Shadi, you are role model for so many of us. All of us see you, look at you, and learn a lot of things from you. So, let me know who is your role model? Who inspired you?
Dr. Ritu.
Ah. Joke of the day. Okay, coming to the next question. So, which is your favorite food?
Sweet.
Okay.
I am obese and have an abdomen, a great abdomen.
What about your favorite fruit?
Banana.
Okay, great. And who is your favorite author? You read lot of things, you post lot of things. So, who is your favorite author?
Help me, give me choices. I wanted to give me.
Chooses. I don't know who is your favorite. I'm just asking you who is your favorite. If any name is coming on your mind.
Yes.
No. Okay.
Yes. Okay.
Now my next question to you. We will take academic questions also, friends. Please be with us. So now my next question to you. What motivated you to become a doctor?
This is my dream from many, many years. As I'm at primary school, I like to be a doctor, as this is dream of me and dream of my mother also. So this motivate me every time. You must be a doctor. You must be a doctor. So this make me. I must be. And not ordinary doctor, but must be a different doctor, unique doctor, make a difference. And this is my mother is the main cause for this.
Of course, you are a great doctor.
Thank
Now,
you.
my another question to you. See, as in our India, once we call by name, as my name is Ritu, the name of the meaning of the Ritu is seasons. So, what's the meaning of your name? What's the meaning of Shadi? Is it anything?
Singer. Shadi means singer.
Singer. Okay,
Yes.
wow,
Song
great.
is all the time song.
Okay, okay, great, great, great. So now so many doctors follow you, Dr. Shadi. So now you want to give some message to the young doctors, young
Yes.
upcoming doctors. Of course, we are also young for the upcoming doctors.
Must read and must find a mentor. We cannot reach alone. We must have a mentor guide us, and also must read and train, reading, training all the time. I am now read and train also. If the doctor stop to read and do training, this means this doctor will die.
Yeah, great. Thank you. So now I want to see, as in our India, we greet each other by saying namaste. So now how in your country you greet each other?
Again, this I don't understand this question.
Actually, okay. Okay, I will simplify this. Can you teach us one word in your language?
Yes.
And any one word can you teach us?
Yes. Salamu alaikum.
Salam alaikum. Okay,
Salam
okay.
alaikum.
Yes, yes, now you got my question, because in our India we say namaste, and in your country you say salam alaikum.
Salam
And
alaikum.
and we have to reply like walaikum assalam. Am I
Yes.
correct?
Yes, you are
Yes.
correct.
Yeah, yeah.
And also the most important word in my life is Masr. Masr means Egypt.
Must means?
Egypt.
Okay. Okay.
Egypt. But in Arabic, Masr. We say Masr. We not say Egypt. This is in English only, but we as an Egyptian, Masr. And I invite you to come to see the great civilization in the Egypt, in Masr.
I must come. So thank you so much, Dr. Shadi. Now we can take some questions. There are a lot of questions are coming.
Okay, ready.
Yeah. So you can also see in the question answer box. Dr. Hebitala is writing, if I suspect septate uterus on 2D in virgins, is it better to do 3D or MRI? In case
3D. MRI is very expensive and give the same result with vaginal 3D. So 3D is very, very important and very informative and also very cheap.
Yeah, thank you. We will take more questions. Yeah, some of our friends have joined. They all are appreciating your lecture. Yeah, thank you, Dr. Nausheen, for joining. Thank you, Poonam ma'am. Yeah, there is one question from Dr. Chinmay. Yeah, thank you for joining. Question is, what's your view on endometrium stretching?
This is old-fashioned.
So nowadays you don't prefer to go for endometrial stretching?
No, no, no. Now we don't do it at all. Firstly, some research is talking about you must do hysteroscopy before IVF. And after that, more researchers tell us there is no benefits from making hysteroscopy. Also, scratching of endometrium before, it is very important. And if you see the old textbook, the scratching of endometrium is very important, but new researchers tell us there is no benefits from it. So we don't do it.
Because earlier, when I passed out 20 years back, that time, of course, we are doing the endometrial stretching. Yes, of course, now the concepts have changed. Yeah. So now the other question is from Dr. Asma. Question is the ideal number of antral follicles per ovary.
Both ovaries, we talking about both ovaries must be 10 to 15 follicles per both ovaries. So if the ovary is, we find 7 follicles in one ovary and 3 follicles in another follicle, this is 10 ovaries, this is normal. But I tell the patient this is very low number of antral follicles if the number is less than 4 to 6 in both ovaries. So we don't talk about one ovary, we talk about both ovaries.
Yeah, another is comment from Dr. Meenakshi. She's writing very informative. Yeah, thank you, Dr. Meenakshi, for joining. And yeah. Again, there is one question from Dr. Chinwe. He's writing the endometrial blood flow or diameter, which is more significant in the successful implantation.
Yes, successful implantation all over the world, there is constant information. The main 2 constant information is trilaminar endometrium and thickness, endometrial thickness, which is from 8 to 14 and ideal from 10 to 12 and must be trilaminar. But there is research about the endometrial volume, the subendometrium blood flow, but this is not a good evidence about it. So we don't talk more about it, but I can talk about it in lecture. But in practical, we don't do it routinely, but we do routinely trilaminar, measuring the endometrium, and looking for trilaminar view of the endometrium.
Thank you so much. There is one more question. Role of subendometrial flow in infertility.
Yes, if there is more blood flow to the endometrium, this means receptivity of endometrium increased, and this helped the embryo to implant in the uterus. This is logic. If there is more blood flow, this means more blood to help the endometrium to take the embryo and the implantation occur.
Yeah, we're getting lot of compliments. Dr. Rita Agarwal, a friend of mine, joined from Hyderabad. Yeah, thank you, Dr. Rita, for joining. She's writing a very informative lecture. Dr. Shadi, another message is for you from Dr. Hibatullah. The lectures of ASFMS on Thursday are very difficult to attend. You can read that.
Yes, as we have a lecture at 8 o'clock by Cairo time, but most of doctors ask us to be at Thursday. Friday is a day of family at all Arab countries, so it is very difficult also to be at Friday. But we can try to change it.
Hope you got the answer, doctor. Now, another comment is from Dr. Janan Ablusavi. Very good and informative lecture, and she is thanking both of us. Another comment is from Dr. Tangela. How to differentiate, luteinized, I think, luteinized unruptured follicle versus late pre-ovulatory follicle.
Yes, this is very nice question. I want to ask Dr. Ritu about your experience in LUFS. Tell me about your experience in your center.
What I tell you regarding is this what you want to know from me? Means for this luteinized unruptured follicle?
Yes. I wanted to know your experience in your center about luteinized unruptured follicles.
Actually, I have seen not much cases of luteinized unruptured follicle. Usually, once if the patient is coming, if it is having a non-rupture, I usually give the recombinant HCG. So,
yes.
So if the patient is not getting the rupture by this normal HCG, so usually I try with recombinant HCG. Usually patient in the second cycle, I found the rupture, but in some patients, yes, of course, some patients is having a problem of persistent luteinized unruptured follicles. Yes, that is correct.
Yes, but this is very, very rare. You may see 1 or 2 cases per year if you are working more and more.
Yeah, correct. Yeah. So thank you. Yeah. Now another question is again from Dr. Tangela. Please let us know the difference in relation to the endometrial changes. I think for that, Dr. Shadi will take another lecture for the endometrial.
Endometrium become follicular phase, then become after ovulation, become homogeneous to enter in the luteal phase, and if the pregnancy not occur, the uterus will cry by blood, and the blood will descend from uterus due to crying of the uterus due to no pregnancy.
Yeah. So yeah. Now another question is, I dropped my WhatsApp message number. Some doctors are writing me for the WhatsApp number, so I already dropped my WhatsApp number. So yeah. Now Dr. Asma is writing. Sorry, I missed the question. Yeah. Dr. Asma is writing, if fluid collection in the endometrial cavity in mid-cycle prevents the implantation of embryo.
Yes, this can interfere with implantation and also may be due to subclinical infection So if I do IVF, I will freeze the embryos and give the lady a check firstly if there is some adhesions present in the endometrium or not. If there is no adhesions, this means there is subclinical infection present in the endometrium, and I will give medications and freeze all embryos and will transfer in another cycle with clear endometrium.
Yeah, very true. The same we are doing. We are trying first with the antibiotics. Sometimes we are aspirating also. Yeah. Now. Yes, I think we have taken all the questions. Yeah. One more question. Yeah. Dr. Gadam Devi. Yeah. She's writing, what medications you suggest if endometrial thickness is below 6 mm, and if so, will you cancel the cycle?
Yes, this is unpredictable. You make follow-up for, according to ISHRI guideline, endometrial thickness, not important to measure it except at time of HCG triggering. So if you check the endometrium at the day of HCG triggering and you see it less than 7 millimeter, for me, I freeze all embryos and there is no transfer at all. And start in the next cycle, and I will give all things. I will give high dose estrogen. I will give sildenafil. I will give aspirin. I will give dinitra. All things, and also endometrium may be not increased. Also, this may be refractory endometrium.
Yeah.
So we try. If okay, we can transfer. If endometrium not reach the proper thickness, we don't transfer the freezed embryo.
Yeah. In addition to this, I want to add, yes, as Dr. Shadi has clearly mentioned,
some researches occur on PRP to
yes,
inject the PRP in the endometrium.
I was going to tell only that. Yes, of course, the arginine sachets also we are using. Arginine preparations we are using. In some patients, this vitamin E also is having a good result. Some patients we are using this nitroglycerin patches, though very less studies with the nitroglycerin patches, but some studies are there. Yes, pentoxifylline I myself have used in 2-3 patients, very good results. So yes, and of course, ultimately, if nothing is working, then PRP. Yeah. So now another question is from Dr. Tangela. How can we explain too thick periovulatory endometrium?
We don't know. We don't know why the endometrium is very thin or very thick at time of HCG injection. We don't know. If anyone know anything, can inform us.
Of course, no. So friends, I have dropped my WhatsApp number and my YouTube details in the chat box. Those want to become a part of academic discussions, please drop me your or connect me on this number with your name and workplace. I will be happily add you in one of the academic groups. So I think with this we will wind up. So thank you so much, Dr. Shadi, for your excellent lecture as always. And once again, we are honored to have you with us. So, and thank you, Climate team also. And thank you, my dear friends who have joined all across the geography. So, thank you once again. Bye-bye. Good night.
Many thanks for you, my dear Dr. Ritu, and all audience. Many thanks for all.
Before we wind up, there is one announcement. Yeah, me and Dr. Shadi are going to start some courses very soon. For this, we will start some courses, and probably the hands-on workshop will be going on at Dr. Shadi's place in Egypt. We will inform you soon regarding this aesthetic gynecology courses we are planning, and with very shortly we are going to inform you. So stay tuned with my all posts in the link in all the social media, LinkedIn, Facebook, YouTube, Instagram. Bye bye.
Okay, many thanks, my dear doctor. Bye bye.